Hi everyone, this is JC Saltzman. I'm presenting my case this week on a pelvic floor patient. The patient is a 7-year-old female. I met her first on April 30th. She was referred from the doctor for pelvic floor therapy and bladder training. Chief complaint was urine leakage, and this had been happening since about 2010. The main outcome tool that we used for this patient was the pelvic floor distress inventory. And if you guys are unfamiliar with that one, it's broken into 3 sections, and with this patient in particular, we only used the urinary distress portion. And so her score was a 10 out of 24. We had goals on there. We expected to see the patient about 6 visits spread out over about 2 or 3 months. The main complaint that the patient had was daytime leakage. This was happening maybe 3 or 4 times a week, which is quite a bit. And then the patient was also sometimes, maybe once a week, experiencing nighttime leakage. The interesting thing I think about this case and some patients that we'll have is that the patient wasn't having pain, there was just a dysfunction. So here you can see maybe some possible sources of symptoms. The main one I want to point out is just that I broke down the different layers of the pelvic floor. Just as a little refresher for all of us. At this point, before I talk to the patient, I'm kind of thinking of ideas, and honestly my main thought is pelvic floor weakness that this patient is having. But also other things on my list: bladder irritants, maybe a psychosocial problem, prolapse, maybe neurological condition, so we'll kind of see once we talk to the patient. Once I did talk to the patient, the aggravating factors for this little girl was laughing and jumping, usually just having a good time is when it would happen for her. And then the nighttime leakage would just occur randomly while she was sleeping. This had been going on since about 2010, and that was when the patient was potty trained, according to the mom. And then since then it's kind of stayed the same. You know, she has some good times, she has some bad times, but it was something that the mom kind of just thought she would kind of grow out of, and she just hasn't yet. No big prior history. She had been seen by the physician and also a urologist who had done testing, and that was normal, but she hadn't had any treatment for this yet. Generally, just a healthy kid, not many problems. I do want to note, though, with a red flag screen and a lot of women's health patients that I've seen, cauda equina is kind of up on the list because they're obviously having bowel and bladder dysfunction. So you have to be careful and ask specific questions about it. The patient didn't have any saddle anesthesia, no back pain, no recent infection, no fever, anything like that, so that kind of puts it a little bit lower on my list. Yellow flag screen was negative. Diagnostic tests and imaging, they had seen the urologist, and they did testing there. I honestly don't know what they do at the urologist, but whatever they did, the doctor said that all of the testing was normal. The patient was not on any medications. So go ahead and take a time out, answer some questions on Moodle. As far as the physical exam, we didn't do a typical upper quarter screen like I do with most patients. Instead, we used an SFMA, and all of those criteria were functional and non-painful except for a few. The overhead deep squat and the multi-segmental rotation both to the right and to the left were both dysfunctional but non-painful. General manual muscle testing was normal, reflexes normal. Okay, the main part of the physical exam that we did with this patient is use the transabdominal ultrasound. And so this patient had really good normal resting tone of the pelvic floor, which was great. But when we had her try to do a pelvic floor contraction, she did have a lot of global activation, so she kind of used a lot of muscles that maybe she wasn't needing to use. And she also had bladder descent the first time she tried to do it. This got better once we kind of gave her better cues on what she was supposed to be doing. But the patient was only able to do about 4 kind of quick contractions before she started fatiguing. And you can see that on the ultrasound. which is nice. And then her endurance was about 2 or 3 seconds when we had her try to hold it, so not too long. And then we also had her do active straight leg. We tried to have her do a contraction and then do an active straight leg raise, and she had bladder descent bilaterally with that. So go ahead and take a timeout, answer the questions on Moodle. If you guys have any other questions, please post them to the forum, and I'll see you guys all on Thursday.